It is so good to see my friend and colleague, Will Bianchi. Welcome to the podcast.
All right, Andrea, thanks for having me. Glad to be here.
So, tell us a little bit about you, who you are, what you do, why you became a doctor.
Yeah, so I kind of arrived by accident on being a doctor. I grew up on the East Coast in Maryland. My father actually was a Navy ENT. And so I kind of grew up around his absence. He was, always in the OR or coming home late from long day of clinic and being on call and using the Navy. And kind of growing up, I was like, I'm going to ever join the military. And I definitely don't want to ever be a physician because that just seems awful. And so I, ended up going into engineering at UC Santa Barbara, moved away from Maryland and didn't love my engineering classes. Wasn't really super excited about the math and the physics. And for fun, I took an EMT class and started writing ambulances in Santa Barbara and I was totally hooked. I was enjoying, what I was doing at work. I was looking forward to going to courses much more than studying any of my, physics stuff. And so kind of struggled in engineering a little bit longer, then made the decision to change halfway through college to study music and also cell biology. And so my decision point for medicine wasn't until, the last month, I think, of my undergrad, where I was like, what am I going to do next? I really like the EMS thing. I'm not sure. So I still was kind of in a little bit of denial about the calling, I guess. And so I took several years off and did things like sleep lab technician work, which is rough. You ever watched someone sleep overnight in a sleep lab? That's about as far as it gets, I think, for night shifts. And then became a volunteer firefighter paramedic out in Maryland, which was free training out there because it's a career volunteer system. And then ended up going on to get a master's degree, which was kind of a pre-medical pathway, and really liked it. And so, my parents were very supportive of me growing up and never really like pushed me towards or away any particular career, which I'm very thankful for. But when it, came time to go to medical school, I wasn't really sure how to pay for it. And I had a couple of friends that joined the Navy. And so I did a similar program to a lot of our colleagues that we met in the Navy, which was the HPSP program. So signed with that. And boy, 12 years went by in the blink of an eye and had a great time. But that's kind of the beginning of, I think, how I dipped my toe into medicine, which was maybe a little bit of an alternate life path, I think. So
I love that story. And even though, we didn't work together a ton in the Navy, we overlapped pretty briefly. But I love hearing people's stories about why they went into medicine and then why, we went into the military is interesting too. And for any of our listeners that aren't familiar with the military pathway and medicine, Will and I both had a health professions scholarship program, HPSP. So they paid for medical school, for tuition. Gosh, they paid all sorts of things. They paid for supplies if it was on a required list, a small stipend. Boy, when I signed up, there was also a bonus. I don't know what's the state of that right now. But I always tell people, and I'm curious what your response is. I always tell people, do not join for the money. Like 100% do not join for the money. I don't care how scared you are of the student loan debt. There is a way. You really need to choose the military because it's in your heart, because they will get theirs. And I'm proud to have served my country, but I also know that they also got theirs.
I can't emphasize everything you said enough. And I think coming from a military family, I had an advantage of at least, knowing what it would be like. And then I think a lot of the fire rescue training is very paramilitary with shift work and, a hierarchy and a chain of command. So I felt like I had a good sense of what I was getting myself into, but you're absolutely right. You can see these chat boards online where people are, doing the long division and trying to calculate the net benefit. And none of that really matters if it's not a good fit for you. And you end up just really disliking the environment that you're in, which might be with a, bag of food that doesn't expire for 5 years in a wet tent. So you have to really have a little bit more than the paycheck. You really need to be working with the right people and doing the right thing and being in alignment with the mission. So
Yeah, very well said. Well, what are you up to now? If memory serves me correctly, you're now out of the Navy.
I'm out for 1 year as of this month, which has
Oh,
been wild. Yeah, yeah. It's been an interesting transition. When I was active, I was lucky enough to be in San Diego for the entirety of active duty time that you give back to the military for that program we mentioned. And I worked moonlighted at a local hospital on the island of Coronado. And so I kind of transitioned to be full-time at that hospital and took over as the medical director for a small group that we have there. So we're the tiniest ER probably in San Diego. We've got 8 beds, but we see about 90 patients a day with increasing acuity, and our speed is quite quick. We're tiny but mighty. So we're seeing, 10 patients per one bed every hour.
whoa.
And yeah, it's quick. We're kind of in urgent care on steroids with a little bit of real true medical emergency, and then a couple of traumas that sneak in because we're obviously not a trauma center. But that has definitely taken up a lot of my time. And then whatever time I have left is kind of spent towards a private practice that my wife and I have started up in La Jolla, which is a ketamine clinic.
Wow. Wow. So ketamine's had a lot of press lately. And honestly, some of it's been pretty negative. I was a huge fan of Friends and devastated when Matthew Perry died. But I'm also an emergency physician, and I sometimes like to think about how many pounds of ketamine I've given throughout my career. I've given a lot of ketamine. I worked at LA County and took care of a lot of trauma patients. And it was different trauma than the trauma I'm assuming you treat with ketamine now, actual, physical trauma, the knife and gun variety, and administered tons of ketamine. And it's a wonderful drug. It's one of my favorite drugs to give in the emergency department. But like every drug, it has its therapeutic indications, and it has people it works well for and not. And I'm, really only familiar with it in the emergency medicine setting. So tell us a little bit for some people that may be not as familiar with ketamine, what is it and how does it work?
Yeah. So chemically, it's an aryl cyclohexamine. It's an old, generic, boring, racemic molecule that we made back in the 1970s. We accidentally made PCP first, phenylphysidine, to try and find a better way of anesthetizing patients during surgery. But PCP caused a lot of problems and continues to cause a lot of problems recreationally. And so really ketamine was born from the anesthesiology and operative suites, and then is really just a very versatile and safe medication that became very popular in the emergency department for many reasons. But in the last 20 years or so, and especially in the last maybe 5 to 7, there's been an explosion of non-surgical and non-anesthetic indications for ketamine. And kind of like you, I was coming to what we do up at our clinic with an emergency medicine hat. I was the research director for the Navy hospital I worked at. So I kind of came at it with a nerd brain. I ended up doing a year of school up in San Francisco studying psychedelics, not just ketamine, but all of them, MDMA, LSD, ibogaine. Did a deep dive on pretty much everything that's still in research labs, and it's, Schedule 1, but ketamine being Schedule 3 has been a big area of interest in mental health because it's readily accessible. And the body of evidence that exists for treatment-resistant depression and bipolar depression was most impressive to me. So I did a real big deep dive on the literature there and was impressed by the treatment effect that I was reading about. And I was also just very dissatisfied, I think, as an emergency doctor working in the ER with the explosion in mental health patients that we're seeing during the pandemic. People not able to see their doctors, substance abuse issues, severe depression, COVID-related PTSD. And as an emergency doctor, I'm not sure if it's different in the shops that you're working at now, but we only kind of have a couple options. I can let you talk to somebody on an iPad that is going to screen you for a psychiatric telemedicine interview. And if you're really serious and really suicidal, they'll, admit you voluntarily. And if not, they provide you some resources. We discharge you. And it's always been very dissatisfying to me as an emergency doctor that there's not more to do because we're very, let's do something right now for this person. Let's place that chest tube. Let's intubate this person. Let's, rule out life threats. And mental health just kind of was frustrating me. We decided to, start doing our own work with ketamine, and we focus on those two things specifically. There's a lot of described research and indications in the literature, like chronic pain, CRPS, anxiety, OCD, depression. And I'm probably among the more conservative physicians when it comes to using ketamine for mental health treatments. We focus really just on treatment-resistant depression, which is someone that's tried typically one, sometimes two SSRIs and has not had good treatment effect. So that's kind of a little bit about the background of ketamine and kind of how I arrived towards using it. But if I can touch on something real quick, it has a very interesting history in the last 2 or 3 years. So there was this Ryan Hate Act that was waived in 2020. So this was, long story short, a law that was put out there saying that if you're going to be prescribed a controlled substance, it requires a clinician to do a face-to-face evaluation of the patient before prescribing medication. And this was because an unfortunate young man named Ryan was receiving, I think it was Vicodin or oxycodone through a telemedicine practitioner and overdosed at home. And the DEA said, no more. This is how the prescribing is going to be. But with COVID, people couldn't get to the doctors. And so there was an emergency modification to this law where, you could still get those narcotic medications to those patients that were in pain. And then there was a couple of companies that got cute and started to do telemedicine where they'd ship out Adderall or Concerta, these other stimulants. And a couple other companies looked at the literature of ketamine, which is usually looking primarily 90% of it describes IV ketamine. About 10% of it describes intramuscular ketamine. But they started to compound ketamine in oral lozenges and then ship these out to people's homes in a telemedicine platform. So there was this explosion of teleketamine companies, there still is, with really not much scientific evidence base at all. And you unfortunately have people that are, doing oral ketamine lozenges in their homes. And I'm also a big fan of Friends. I think that's a good example of someone with, suffering from very severe mental health and also some concomitant substance use issues that successfully, I think, went through supervised IV ketamine, but may have had access to some additional ketamine somehow. And when you combine something like ketamine with, hot tub or a pool, and you're not being supervised or monitored, it's very easy to slip below the water, and that's that. So the last few years has been very, very interesting. We're a clinic that does, treats it the same way we do in the emergency room. It's a, one physician, one patient with monitoring in a very safe setting. But there's a lot of variance in how ketamine is used right now. And a lot of that has just been sequela from the pandemic.
Thank you so much for reviewing that, because I remember being in my car listening to one of my favorite podcasts, probably, 2 years ago, and a commercial came on about how you could get ketamine delivered to your house. And I'm like, there's no way that this is happening. I'm like, how do you do it? It just defied all reason, because the little bit that I know about ketamine or, any psychedelic or any of these, newer treatments, old but new treatments for mental health issues is
Set and setting.
so could you explain that to the listeners? Because that's what I'm concerned about with a lot of people doing ketamine at home is they really may not be in a safe setting to get what they need from it.
Yeah. So set and setting refer to really, if you boil it down, the patient, the client, their mindset. And this touches on things like the intention for this. Ketamine is not truly a psychedelic, it has psychedelic like properties, but the intention for the experience or the infusion that they're about to have. And we see this in the emergency department. We use ketamine to reduce the shoulder. And if someone is really anxious, well, it's probably not the moment to give them a push of ketamine because it's going to really heighten that. And they're going to have a very, very bad experience on that medication, especially once you start pulling on an arm. So the mindset or the set is really important. And then the physical setting that you're in, and oftentimes the emergency department, is not the ideal setting. But the physical setting is really important because things that are occurring around you, how safe you inherently feel, if you're with someone that can help you if you need help, because nothing in medicine is without risk, and ketamine certainly, it sounds like you've got no shortage of experience. Things can happen, and so we monitor patients, we recover patients, we have emergency plans in our mind for the worst case scenarios. That's just what we do as ER doctors. Anesthesia does the same thing. But when people are in their homes, not everyone's home is a great place or a safe place or a reproducibly relaxing place. So yeah, that's great. Those two things are kind of the tenets of this very early developing science of psychedelic medicine that are paramount.
I think what also is fascinating listening to explain that is that was never taught to me as an emergency physician. I just intuitively learned it over time. So I've learned, I've learned that there's certain patients, as you've kind of outlined, that ketamine's just not going to be a good fit for them during their emergency department state. And there's other people that it can be, but what you're saying to get them in that mindset that even though they are in a busy, noisy place and something inherently traumatic happened to them, when they arrive to the emergency room, the only reason we are giving ketamine to someone is because something traumatic happened to them. And depending on their trauma history, how fast they move through that and are able to get to a mindset of, yes, I'm anxious, but, I can visualize that I'm, my favorite vacation spot, or, I feel like a high level of trust with the team and, I'm ready for this medication. No one teaches us that. At least I never received that education. And in fact, I've had people when I get into kind of my woo energy, when I'm about to give somebody ketamine, roll their eyes at me like I'm a nut job. And you're shaking your head. Explain why that's so important.
I totally agree with you. And it's really interesting. Yeah, I never got that education either. And it's kind of that art of medicine, it's not until 10 years of using medicine that you start to really get to have this intimate familiarity with them and who's maybe not going to be a good fit for, this type of approach or this type of medicine. But the woo is great because I have many colleagues that have kind of arrived at this, knowledge gap that they're closing. And I have friends that will, ask clients, or patients in the ER, what kind of music do you like? Let's turn the music down. Let's get you relaxed. Let's talk about the beach that you like to visit. And really that can make things so much easier when you're recovering them from the procedure. And we have to in the emergency room, right? Because it's just absolutely chaotic, and we're meeting them usually on the worst terms. The nice thing about what we've been doing up in our clinic in La Jolla is that I can, I never give an infusion the first time I meet someone. We always have like a 1 hour intake where I really get to know them and their story and kind of talk almost like how we're talking now. And then if we determine it's a good fit, we start working together. And our appointments are like 2 hours long. The infusion is only 40 minutes, but it's really nice because we can totally have all the time to control that the setting that we're in. There's a lot of familiarity and a lot of people that will come in and burn some Palo Santo or stretch on the floor or do their own woo and try and make sure that they're as prepared or ready as they need to be. But it really just makes the experience much more predictable. And in ketamine, especially from our military background, right? When we start talking about low, medium, and high doses, and it's described a lot of different ways in the literature, psycholytic dosing, dissociative dosing. It's very different if you're to give somebody a very low dose, a certain route versus, a 500 milligram intramuscular dose, which is what we will frequently use if someone's having a behavioral health emergency, it's physically dangerous, or needs to basically be protected. So they're really interesting medicine. And it's funny. Yeah. There's no chapter on that in any of the books that we read. It's, indications, contraindications, dosing, what to do if there's an emergency.
So I want to switch gears a little bit and talk about something that's been in the news. So I heard just a few days ago, I was listening to NPR and they mentioned that ecstasy was under FDA consideration to treat, I believe it was PTSD, and the FDA ultimately decided to not approve it for that indication. And so I'm curious on your thought about ecstasy as a therapeutic intervention. And I'm sure we'll branch off into some of the other, is that a psychedelic? I'm even like clarifying, is ecstasy considered a psychedelic?
Oh, I would say yes, but some of the purists and people that are deeper in the field would disagree, but I think it is.
For this conversation, we'll say psychedelic-ness.
Yeah.
Yeah. So tell us a little bit about what that was about and your own opinion, since you know so much of this literature.
So the meeting that you're referring to that occurred last week was an FDA panel. And essentially what they were doing was reviewing the two recently completed phase 3 trials coordinated by the Multidisciplinary Association for Psychedelic Science, MAPS, which has since renamed itself Lykos Therapeutics. I could probably talk for days and days about MDMA, and it had just a really outstanding history. Actually developed in 1912 Merck was trying to develop a combat trauma medicine, a procoagulant medication, which really ran right next to what I was doing in the Navy. But it got about a 30-year history, really ever since it was rescheduled to Schedule 1 back in 1985, where someone, his name is Rick Doblin, has been pursuing this with MAPS and doing phase 1, multiple phase 2 trials. And then in the last 5 to 7 years, completed, the phase 3 trials that are typically reviewed by the FDA. So the meeting that occurred last week was a panel of multiple pharmacologists and mental health and physician experts reviewing the quality of the evidence produced by these trials. And the data that they had published in very reputable journals, I believe it was Nature Medicine, was very impressive. They're giving a dose of oral MDMA to a patient and then having them sit in a room with a dyad. It's usually like a clinical psychologist, dyad, a male and a female. And they get 3 doses of MDMA. There's integration sessions and some pre and post counseling as well. But they found some really impressive reductions in PTSD severity. What the panel was reviewing last week was kind of a deep dive on the structure of the trial and kind of where the gaps were in the science. And then they voted on their recommendations to the FDA. Their final decision will be in August, but they ultimately overwhelmingly voted to not support it. And I think I definitely identify as a clinician scientist. When you look at the science, when you really read into the data, there were some issues in how they did the studies Some of that is inherent to the nature of psychedelics, right? When we talk about doing a blinded study, neither the researcher nor the participant should know if they received the study drug. But when you think about somebody that had mushrooms or LSD, it's really hard to not know that you just received that. The same is true for MDMA. So there's issues with what's called functional unblinding, or your study subjects knowing that they received the study medication. There's also some complexity with how they designed the trial, with the type of therapy that was being provided, and then some smaller issues with regard to safety data that they didn't completely collect. And there's also a little bit of bias in their patient population. They actually, when they're looking at the types of people that were enrolled, about 40% of the people in the studies had experienced or taken recreationally MDMA before. So there's inherent bias kind of in the study design and also the people that are going through these studies. That being said, the data, the videos that I've seen, and I actually went through the MAPS MDMA assisted therapy training myself, is very impressive and has really fantastic and promising implications for mental health and the treatment of PTSD. And I think what was really cool about the committee hearing, and it's a very long 8-hour hearing, but there's highlights on YouTube, you can Google it, is that there was a lot of hopeful kind of discourse and a lot of promise in the treatment. But with the research that was presented from these 2 phase 3 trials, there was a lot of concern that the science was just not adequate enough. And, the FDA, I think I disagree with some of their decisions. Often there's been some Alzheimer's drugs that have been, recently pushed through with some dubious science. And even when you look at something like S-ketamine, to go back to ketamine, but the isolated enantiomer of ketamine that's been put in a proprietary nasal spray for treatment-resistant depression for patients that are taking an SSRI, the data was not fantastic, and it was pushed through and approved. I think it was a kind of an eye-opening week for a lot of people. I think that it was very promising that the FDA was even to the point of reviewing something like MDMA-assisted psychotherapy for PTSD, because there's not really much else. I know you're very familiar with this because you're very close with active and veteran patient populations, as am I. The medications, frankly, that we use to treat that suck. They have a lot of side effects, and a lot of the other therapies are kind of hit or miss. The trauma-informed psychotherapy, and it's frustrating, and it's a very deadly disease that results in a lot of comorbidity and suicide. So kind of a tumultuous week, a little bit disappointing having followed this for so long, but also some really important scientific scrutiny that I think will ultimately provide the direction that Lycos and MAPS needs to design and create and produce the science and the results that are required to someday hopefully bring this mainstream.
I'm curious, have you watched Hulu's show 9 Perfect Strangers?
I have.
Yeah. So as somebody that understands the science of these drugs way, way more than me, I mean, I will say, I have a book coming out this fall, and I talk quite a bit about my own journey with emotional trauma, post-traumatic stress symptoms. And I haven't done ketamine, or actually I haven't done any medications at all. I've done various forms of cognitive behavioral therapy, and I did EMDR, which I know you're familiar with, eye movement, desensitization, and reprocessing. I've talked about it before on this podcast. But watching the TV show 9 Perfect Strangers, from my emotional side of research and exploration and books that I've read, that series made a lot of sense to me, and I thought was a really good depiction of emotional trauma and how we get caught in loops. And to me, the takeaway from that series was, I don't think you should microdose anybody without them knowing, first of all. But the main takeaway was that these medications have the potential to unlock people and to speed up things, and the things that you keep getting caught on, that it seems to kind of let that go in a way, like the hallucinations that people had of like having a conversation with a dead family member and how profoundly healing that could be. Did that series in your scientific mind kind of artistically show what's happening or what you've seen with patients, or was it just Hollywood?
Yes and no. I think it was a very entertaining series. I think a really excellent one for anyone that's hearing us chat is based off of the Michael Pollan book, How to Change Your Mind. It's a 4-part miniseries on Netflix, and they touch on LSD, psilocybin, MDMA, and peyote, and does a really fascinating dive into the history of each of those psychedelics, the science that's kind of very early, and the research surrounding it, and also some of the indigenous history, especially for things like peyote, mescaline. Ayahuasca has a lot of really interesting history, as does iboga or ibogaine. So I think I prefer that show just because it's based off a really fantastic book. Michael Pollan is very articulate and a very good skeptic and does a great job. And I think it captures some elements of the show that you're mentioning, where you really see on this show videotapes from these clinical trials, where that unlocking and those moments of, I describe to my clients as getting unstuck, can occur. And we do see that with ketamine. I describe it as the therapy that's really good if you're stuck where you are, if you are curious, and if you're hopeful. And if you're doing it with the right mindset and the right setting, it can be really impactful and get people unstuck, which is how we use it, because the durability of ketamine is still being described in the literature, still being looked at. But a lot of these psychedelics seem to offer those types of mystical experiences. But that being said, I totally agree. Microdosing or dosing anyone with any medication, absolutely terrible idea. Is only going to cause harm. So I think I point a lot of people to that mini series just because it's just so well put together.
So I want to shift gears again and really turn to Will Bianchi. And what I find absolutely fascinating about the conversation that we've had today, and I'm going to start with the preface that we're both emergency physicians. We've had conversations that there's some real problems with our specialty, and we don't need to belabor it. If you're listening to this podcast, there's 80 other episodes that you can listen to us complain about the state of medicine. But I'm curious, emergency medicine, I sometimes think like the interactions I have with people sometimes are, 5 minutes or 7 minutes. They're so brief and often very superficial, right? Like with that amount of time with somebody, how would I ever expect them to share? They do share, but it's hard. You can't really do what you're doing in the ketamine clinic. And so what I'm taking the long way to ask you is, when you think about an emergency doctor and now what you're doing, having a 2-hour visit, I'm guessing there's somebody that just listened and they're like, what the? 2 hours, but you're smiling. You're joyful. I can feel it through the Zoom. Walk us through that.
I should preface this by saying I've always been very interested in psychiatry. And I think another kind of card I have is that my wife is also a physician. She's trained in pediatrics and then did a fellowship in child neurology. So her clinic visits are like routinely, 90 minutes long. And it was a big adjustment for me at first, because we do barely have enough time to establish rapport and come up with a plan. And if we're lucky, we get a chance to see the patient a second time before, we discharge them or admit them. And it was really hard at first. And I luckily had kind of the guidance of my wife, who was able to slow me down and kind of explain, what works best in clinic for her and what it kind of feels like. And it took some adjusting, but I started to kind of lean into it and really enjoy just having a place that I was providing medicine that was on my own terms with the clients that had found their way to me, because we don't really do any advertising or marketing. Everyone we work with kind of just gets in touch with us. And I found that to be really satisfying. I didn't have any metrics over my head. I didn't have, 20 other people in the waiting room to go see. It was just me and that person looking for help and me figuring out how we can help them feel better. And, for 40 minutes, they're also wearing an eye shade and listening to music. And so I get to put on kind of my anesthesiology hat. We wear a lot of hats as emergency doctors. So it's not quite the same as a 2-hour, intensive, mental health appointment. There's elements to it that are nice as well, because we don't get a lot of follow-up or continuity in the emergency department. And if we do, it's usually not for the right person or the right reason. They're usually coming to the ER quite frequently. But it's really amazing to take someone that is so severely depressed. And we've had people that really just are on the verge of suicide, completing suicide, and pull them back from that and refresh their perspective and help them reset in a really kind of interventional way. It's an interventional mental health model, really. That's what psychedelic medicine, I think, is aiming towards. And that speaks to emergency medicine and kind of what we come from, doing a defibrillation on a heart or giving a medication that works right away. This isn't quite as immediate, but it's pretty quick. When clients work with us, we're getting things done in usually 2 or 3 weeks, which is really fantastic, both for them and for myself as a tired, on the verge of burnout at times, ER doc. So took some getting used to, but had a lot of really kind of exciting nuance as I went through it.
Well, my call to action for listeners is this just has to happen. We just have to, I think the number of psychiatric patients coming to our emergency department is unsustainable. The system is beyond the breaking point. We're putting them back into a system that's also not solving it. I don't know if it's because there's not enough people or we don't have the modality correct or a combination of both. And what I know about emergency physicians is we're really good at fixing shit. And we have resisted the psychiatric realm. We have pushed it away and we have said, it's not us. We don't do that. We'll be the triage person to call mental health, but we're not engaging in this. And where has it got us? And I do think that there's something, if I dare say, I think you and I are both in this mid-career category. I always tell people what brought me to emergency medicine isn't keeping me in this specialty. I don't know how you were, but at the end of residency or the first few years as an attending, a really good recess, going right up to the brink of somebody and pulling them back from death was amazing.
Yeah.
And I still feel good and I'm proud of taking care of them. But I also have this knowledge that sure, if I wasn't here, somebody else would have done it. Right. I'm not really convinced that I'm that special in that regard. And now when I have these, a person that's in emotional distress or, needs this different level, it wasn't accessible early on in my career. It wasn't something I wanted to do. I didn't have the skills to do it. And now I do. And I'm like, then we just need to start doing this. I don't know if it's a 1-year fellowship in psychiatry that's offered to EM, but I think ASAP, AM, I don't care how many letters, we all need to start just putting our heads together and saying, we're going to do this. And maybe it's training 5,000 emergency physicians, setting a goal that we are going to get them certified to do these infusions. Because I've had patients say, can I follow up with you? This was helpful. Could I talk with you? And I'm like, I'm sorry, I don't have a clinic. I don't do that. So how fantastic would that be if we began to have a network of saying, I have so many friends that have aesthetic practices, and I'm very happy for them. I'm short on my Botox right now, and I'll be getting, but we've proven that they can do that, and they can go out and get some additional training and do that safely. Let's also do this for something that is as important and life and death as mental health. And I know I'm on my soapbox, but I'm just like, we've got to do this because what's happening right now isn't working.
Totally agree. Totally agree. And emergency physicians, we can do a lot. And certainly within the mental health realm, we're not psychiatrists, but boy, oh boy, do we see a lot of psychiatric patients. So it's definitely something that I think fit as a specialty. We have a lot of co-ownership over with our mental health colleagues.
One of the questions I like to end with is medicine is hard right now for doctors, patients, and everyone in between. What makes you optimistic?
More recently, my role that I've been filling at my group as director has been filling my cup more than I thought it would. The individual that fills that role that I perceived as making sure that both the patients and the department and the physicians are all cared for so they can provide and receive good health care is really important. And I'm lucky enough to work in a medical setting where the hospital, the foundation that supports our hospital, and our group are all aligned in a vision of making certain that everyone's cared for, and being able to make sure that all my physicians are happy, that they have good schedules, that they have all of the tools that they need to practice medicine and provide the care that they want to provide, has been making me feel really optimistic. It's a group that is physician owned, and it's for the physicians. So it just brings back some autonomy and some ownership for us in the emergency department. And that to me has been really revitalizing. That being said, it is a really hard time. And the more that I read from ACEP and AEM about the influence of private equity, the debt that private equity brings to the picture, the profound influence that they have just in the contracts that they manage, and the pressure, the downstream pressure that comes from these groups and is placed directly on the shoulder of the emergency physicians and the departments that they work in, is really disheartening. It's really, really disheartening. And I'm not sure what's going to happen, because I kind of used to have a fairy tale in my mind that we were going to get through COVID and everyone was going to keep banging the pots and pans and understand that the emergency department is where the heroes worked and come out and help us make things better. And instead, we're really left in this kind of aftermath hangover where ERs are boarding longer than ever. Wait times are just excessive. And the physicians, everyone that works with them are beaten down. And that's a symptom really of the status of healthcare. It's concerning. And I really hope that some of the legislation that I'm reading about ACEP pushing forward is fruitful. And I really hope that society kind of realizes at some point how broken things are, because they need to be fixed. They really, really desperately do, because our safety net has too many holes right now, and it's just getting weaker and weaker. So it's hard for me to be optimistic, but it's a tough time.
And I hear you. And I really appreciate how you framed that for our listeners. And it's something we have to keep talking about. And I've now decided that I will have your episode come out before the episode with Leon Edelman. And just briefly as a little teaser for the listeners. So Leon Edelman is also an emergency physician, and he's founder of Ivy Clinicians. 100% recommend that you follow him on LinkedIn. Leon started a platform called Ivy Clinicians, which sounds, kind of simple and like, how does this tie into fixing emergency medicine? But he's created a job board in which every single job, every emergency department is listed on Ivy Clinicians. So if you're unhappy in your job, you can go and look. Or you're happy in your job, you can go and look. You can go and see what's the size of the emergency room, what's the pay, all the stuff, all the stats about the job. And, he discusses how that's a very basic step in creating transparency. We have to get that level. And then the episode goes into some really exciting and innovative things that we could be doing that wouldn't be that hard. And I'll leave it there. But he said a couple of things in that episode that blew my mind. And I'm pretty immersed in this world, and I'm pretty familiar on strategies to bring back physician autonomy. And he blew my mind with a couple of things he said that has got me incredibly optimistic. But as we wrap up, how can our listeners connect with you? I have my top audience is San Diegan. So perhaps they know somebody that maybe they need it, or they know somebody that would want to seek your services or have an evaluation in your clinic.
Sure. Yeah. Yeah. Well, so we're located right up in La Jolla. So we're pretty central to things. Our clinic name is Maverick Medicine, and that's the website, maverickmedicine.com. Not Tom Cruise or U.S. Navy Maverick. This was just a word for me that means that it's an independent-minded, or maybe a little bit more of a radical approach to something, which is, I think, the approach we're taking to mental health care. You can reach out on that website, or even just give us a call, or coordinate a lot of phone calls for anyone that's interested, because I just feel an obligation to make sure that people are informed and they kind of understand the nuances of ketamine, because it's the Wild West. There's, oral ketamine and rectal ketamine and people doing all sorts of silly stuff. So I try and just chat with them to make sure that they're pointing in the right direction. But it turns out that they're maybe not a good fit. They know where to go next. So, and then we have an Instagram as well that I will need to work on. But I wanted to say thank you for having me on, Andrea. I was actually trained under you. You were finishing up your senior year, actually, when I came on through the Navy hospital that we both worked at. And I remember reading a publication you had put out in Annals about falling back in love with emergency medicine. I'm not sure if that was the actual title today. I remember before I logged on to chat with you, I remember reading that article when I was a medical student, like really impressed with how articulate it was. And articles like that, I kind of big nerd with Annals. I love saving papers. Some of them are so potent. But I keep those for moments when we have, rough shifts, or you kind of feel like you lose your way a little bit. And that's one that's been really, really special to me. So glad to see what you're doing here on the podcast. And I'm definitely very proud to know you and know that you're doing this work, and really fantastic job. So look forward to hearing about the Ivy Clinician. It sounds like absolutely step in the right direction. Transparency is totally key.
Oh my God, that is so amazing, Will. It's so funny because that article, I look back on it and it was good, right? Like there were some good pearls in there, and it was processing, kind of that post-residency phase of my career. If you like that, hold on, baby, for the book. The book is so much better. It's just like, that is so wellness 1.0, and we're on wellness 3.9. I'm telling you, I'm so excited to share it with people. And yeah, gosh, it's an exciting time, and it's been hard, right? And I think everyone listening, and Will and I are going to do it right now. Like, COVID sucked balls and it hurt in ways that we'll feel the rest of our careers. And there's other things in our specialty that hurt. It wasn't just COVID. And, we're coming out the other side. I think what you're doing with ketamine and what I'm doing with writing and the pod it's post-traumatic growth, right? We couldn't stay where we were. And so we're branching out in new directions. And you're doing that as a medical director too. So right back at you. So I can't wait. We got to do, maybe every year we do this. We just kind of check in, and we should definitely not just meet on the podcast, but the podcast check-in. There's a list of people that I like to check in with once a year. And I think whether you wanted to or not, you've been added to that club.
Well, thank you. It was really nice to chat with you. And I look forward to doing a couple more deep dives from the other episodes. Yeah. Thanks.